There's an implant library with Astra compatible, Zimmer compatible, Noble Active compatible, Straumann, Noble Replace compatible implants. You can select diameter and you can select length, mandible, maxilla. I brought an implant in. It's the same as I showed you previously. I lined up, I got my angulation of this implant from the pan and the angulation of this root here. I then used the abutments as virtual teeth. I fine-tuned my mesial distal on the model. Went back to center lines. Brought in the articulated model, projected it onto the cross-sectional views, now here's a good example where I couldn't get it on the lingual cusp. I'm lingual to the lingual cusp because that's the best we could do because of the anatomy of the bone. But at least you know it before you do the case and not afterwards. So now we have the mesial distal, we have the buccolingual. And now I go check with my 3D the relationship between my second bicuspid implant and the first bicuspid. And we have a plan. You also can get density measurements up and down the implant. I find this to be extremely helpful in planning my drill protocol, whether I undersize or not, whether I countersink or not, or how much, et cetera, et cetera. That's very, very helpful information. This software has something called a tangential view, which allows you to swing around the implant 360 degrees and see its relationship to all adjacent structures. It's a very powerful feature. So right now, it's in a panoramic view, as you would get in a periapical film. So I can see the root of the adjacent bicuspid. Now as I swing it obliquely, now I'm in a cross-sectional view. I can see how much buccal bone I have. And now back to a panoramic view. So you can, on any structure, you can place, you can activate, and you can center it in this field, and you can see the relationship between all the adjoining structures. Very, very powerful feature. As you can see also, we outlined the mental foramen and the inferior alveolar nerve. So basically, all the important anatomical features are known when you go into this surgery. This is a set of surgical slides on the case that we just did. So, here's the planning, which you've already seen. And this is a ThinLayer case. So this is done differently than a tube case. Conceptually, this is very different than a tube case. And this is something you would use in a situation where you couldn't use the tube because you had inadequate vertical space. So in this case, you use a tube guide with an insert and an endo file or a spear drill to create a bleeding point. That's one point of the trajectory. You remove the tube guide and place a ThinLayer guide. Here's your bleeding point. So the implant trajectory is defined, instead of being defined by the top and the bottom of the tube, the trajectory is defined by the guide tube, the guide hole here, and that's exactly the same position and height as the top of the steel tube or the metal tube that you saw, and this bleeding point here. So now you take a thin spear drill in a drill stop, and you place it through the guide hole, through the bleeding point, right through the gingiva in the bone. That makes a pilot hole in the bone. At this point, you have the option of going flapless or flapping it. I raised a flap here to illustrate how easy it is to raise a flap with this kind of a guide. So here's your pilot hole in the bone. It's only 3 millimeters deep or so, about 1.5 millimeters in diameter. You would then place the ThinLayer guide on. This is a 2 millimeter twist with a drill stop. And this is where you can see it requires no more vertical clearance than freehand drilling. It's as if the guide wasn't there from that point of view. So now you place the 2 millimeter twist at an angle. Again, this person can't open very wide. Tip on the bone. You drag the tip back until it's in the osteotomy, in that pilot hole. You drop the stop into the guide hole, and you drill to depth. This flange determines depth, and the depth was programmed by you when you did your treatment planning. So once you have your 2 millimeter osteotomy, you then repeat the procedure with subsequent twist drills. Tip onto the bone, drag back, drop in, drill to depth. So basically, it's the same as freehand drilling, except you're guided, and I use this in second molar sites. If I can get a handpiece back there without a guide, I can do this in a second molar site. And here you have your osteotomies, full diameter. What I also would like to show you is we use the ThinLayer guide to center a cortical drill, to center a tap, and certainly to center the implant driver when we're placing the implant. And it's so easy. You have full visibility. You can see where you're going. You can adjust the implant depth exactly where you want it. I personally feel that guided surgery has become synonymous with flapless surgery, and I think that's wrong, since I like to flap the majority of my cases. And I have a whole series of technical reasons for wanting to do that. And here's the final implant position. And I put the tube guide on just to show that the ThinLayer guide delivered the desired trajectory pretty much as the tube guide would have delivered. So that's an illustration of the case that we just planned.